Thanks for having me. Appreciate the intro. Can everybody hear me? Is there a doctor in the house? All right. So hopefully I think there's probably at least one or two physicians in here. And so you all know that if I start having chest pain up here on stage, right, you're going to have a certain number of tests, although limited, and treatments, although very limited, that you can provide to me right here on stage, right? But what are you going to really do? You're going to call 911, and you're going to get me to the emergency room, right? Where there are going to be more tests and more treatments, right? They're going to be able to, you may be able to check my pulse here, you may have some aspirin, but when you get me to the emergency room, they're going to have an EKG machine, they're going to have a cardiac CT, and if I'm truly having a heart attack, then they're not going to discharge me from the ER, they're going to admit me to the ICU where I'm going to get more tests and treatments, right? Like that's how most of medicine works, right? So they're going to bring me up to the cath lab where they're going to pull the clot out, they're going to stent that artery or whatever the problem ends up being. But in psychiatry, it's different, right? How does it go in psychiatry? So in psychiatry, the patient comes into the outpatient psychiatrist's office and says, I've been thinking about ending my life. I've been researching ways to do it, right? And so what does the psychiatrist do? Politely steps out of the room, calls the police. The police come. They handcuff the patient, put them in the back of a squad car, and drive them to the emergency room, where once they too get to that emergency room, and then they're strip searched and placed in a hall bed, waiting for a psych bed, psych unit, right? And then when they get up there, they're told, we don't have any additional treatments for you beyond what was available as an outpatient. And they're told also they have to go in front of a judge and plead their case of why they want to leave the hospital earlier and that they're safe to leave. And then the patient realizes that they're stuck in the psych unit. And unlike the rest of medicine, in psychiatry, as you escalate the acuity of care, you on average, and we can get into details, but on average, you lose treatment options and there are no tests, right? Everybody on the same page with that one? And what's even more striking is that your suicide risk at discharge is triple what it was for the rest of your life, right? So the highest risk period for a mood disorder patient is after the first admission to the psych unit. And so we've been very interested in trying to challenge that problem, right, and solve that problem. And that's the problem of matching the acuity level of the problem with a treatment that can work in the same time scale, right? Which is very different than how we have been dealing with psychiatric illness, mental health struggles, right? We have largely thought about treatments that work over the course of months, right, to get well. And so, we've been trying to challenge that particular issue. And the first way that we've done it, I came up here a little bit earlier trying to make sure this video would work, so I think we're going to get it to work, is with neuromodulation. And so we've been very interested in this idea of being able to do personalized network mapping of network nodes that are involved with mood regulation. In this case, the dorsolateral prefrontal cortex and its inhibitory connection to an area called the subgenual anterior cingulate cortex. And so TMS, or transcranial magnetic stimulation, has been around for some time, since the 90s as an experimental therapeutic. But in the 90s, when this was developed, it was developed using ruler measurements that provided average skull positions, right? So you're stimulating in the same skull spot in everybody, but you're stimulating in a different brain spot in each person because you're not personalizing based off of their brain network anatomy, you're personalizing based off of their skull position. In many cases, you're going to miss the stimulation target because you're effectively doing it blindly. Does that make sense? And so that's the way that this has been done over the last 20 years. It's like signing up for heart surgery with an average chest circumference. How many of you would want to do that, right? And so what we have looked at is this idea that each network topography is different in each patient, and so can we network map each patient and then have a personalized brain-based target for stimulation in each patient. And in that case, we can use, in this case, a TMS coil to engage the target. And we do that using Faraday's law, right? This idea that if you induce current in electrically conducting substances, you can, if you pulse magnets in electrically conducting substances, you can induce current. And like Morse code, we can do it with a signal that can be interpreted by the receiver. In this case, it's the brain with the hippocampal slice physiology patterning that is the memory signal of the brain. We can do that over very short periods of time and have developed something we called SANE, or Stanford Accelerated Intelligent Neuromodulation Therapy, that's able to apply an entire 6-week course of conventional TMS over a single day. So we personalize the position in the brain, and then we're able to apply stimulation based off of the native rhythms of the brain. And we do it based off of something called space learning theory. How many of you used note cards to study in college, right? Did you write out about 60 of them and then look at them over and over again, right? That's actually space learning theory, right? So we can actually emulate that with an external stimulator and turn that brain region back on and kind of retrain it to learn how to keep that brain region on. And so we're able to utilize learning principles and then exogenously send signals into the brain to be able to get the brain out of these high-risk states. And so we're able to, in this case, as I said earlier, apply 6 weeks of stimulation in a single day. Or in the case of what we've done as a clinical protocol, applied 5 times that. So we're able to give large amounts of stimulation over very short periods of time. And that's actually the sort of time period that we're working off of for an inpatient psychiatric admission. The average length of stay is about 7.4 days. So if we can get people well, give them a day to get in, give them a day to leave, 5 days, and we can get folks well. That's very effective as a solution to a problem that you can then discharge the patient out to, and it deals with a lot of the health economics issues that folks have largely had to deal with as far as long length of stay for patients that are mental health patients in a psych unit. And so with that, we were able to achieve remission rates that were strikingly higher than conventional stimulation approaches. This led to FDA clearance. This led to, breakthrough. It led to breakthrough status, FDA clearance, and then it will be paid for by Medicare in 2024 on psych units. So most of that data came out of the work that we did here at Stanford and from philanthropists that supported the research. So folks can have real impact in these problems from giving, which is great. I don't know why this thing doesn't want to advance my slides. Let's see. There we go. Okay. Next part of the talk. So I was going to give a talk on some of our psychedelic data, but it's under embargo with a journal, and I'm not so interested in making them upset. So if there are any journalists in the room, this is under embargo. Can we agree to not publish this? All right, great. Great. So we've been very interested in a phenomenon that's been going on for the last 5 years, where veterans have been leaving the United States and going out to other countries, particularly to Mexico, to take psychedelics for mental health struggles. And in the case of special operations veterans, so Army Rangers, Navy SEALs, those sorts of fighters, those groups have actually gone to Mexico to take ibogaine, which is a root bark extract of an African tree from the central West African country of Gabon. It's an obscure psychedelic. It's not a party drug. It's something that's used as a sacrament in those countries. And these folks would go down to Mexico and come back and, when I talked to them, tell me that they had had a dramatic improvement in their symptomatology. The Bwiti, which your Bwiti in Gabon, if you've taken iboga root bark, that group would take this as a sacrament for group cohesion for various symptoms. And it's been going on for centuries. And these are the Bwiti taking the root bark. And what's interesting is that they describe, as do the veterans, describe this psychological phenomenon where they have these autobiographical replaying of earlier life memories where they see traumatic events, they're able to see it from a third-party perspective, play that information back and forth, and be able to reevaluate that information like they're a third-party participant in this. They're not experiencing it as self, which I thought was really interesting. And the first thing that popped into my mind, as a child of the 90s or whatever, is this Minority Report movie where Tom Cruise was able to see the same sort of thing, right? You can play back and forth, past memories and have some level of control over them. And this is what most of our veterans describe. They were able to see their trauma again. This is what the Bwiti describe. And so, we were tasked to evaluate a number of symptoms related to, war trauma. And we didn't know exactly why these guys were going down there. So we did this very broad look at why folks were going down to Mexico. So we looked at PTSD scores, which you can see a range, looked at depression scores, anxiety scores, and we were quite surprised at what we saw, which was very dramatic improvements in PTSD. And for a lot of folks, they were able to hold it out to the month. So really striking. I actually told my postdoc to delete the code and rerun this because I didn't buy it the first time I saw it. Anxiety improvements as well as depression score improvements. So really striking. After one dose of ibogaine, the primary alkaloid of this iboga root bark, and this is disability scores from traumatic brain injury on the HUDAS, which is the World Health Organization disability scale for traumatic brain injury. This is another way of looking at it, and I added a few. How are we doing on time? I can do a few more. We're good? All right. This is moral injury, so folks who did something that they, kind of had to do or accidentally did on the battlefield, they don't necessarily, have a hard time kind of dealing with, like they accidentally left their buddy on the battlefield, they accidentally shot a civilian instead of the enemy, and so reduction in those symptoms, reduction in suicidal thinking, increases in executive functioning and key kind of executive functioning areas that are involved in kind of frontal circuitry like cognitive flexibility, cognitive inhibition, processing speed. We saw volume increases in key emotion regulation areas like the left insula, the frontal pole, as well as white matter volume, whole brain white matter volume increases. What's interesting, one of my postdocs got really interested in this idea of accelerated brain aging and the idea of this machine learning algorithm that can, get your brain age, right? And so not everybody's brain age and their chronological age is the same, but the machine learning algorithm's been trained on hundreds of thousands of brains, so it's able to basically get a good sense of that brain age. We saw a reduction in overall brain age at the 1 month mark, which is interesting. We fed some of our sham TMS data into this at the same time points. There was like no change. So we're going to look into that, as well as increases in cerebral blood flow and key emotion regulation areas that I talked about earlier, the insula, the amygdala, cingulate. And some of those blood flow changes were correlated with improvements in the disability score, particularly the insula, which is an interoceptive organ. It's related to kind of sensing your body in 3D space. And that was, even the subscales were correlated. as well as changes in brain connectivity, so how the brain is connected to itself. So we're really interested in trying to work on and develop and find rapid-acting treatments for neuropsychiatric illness. We're trying to solve some of these problems of how do you have a treatment that matches the acuity level, and appreciate the ability to share some of this with you. So thank you.
Thanks for the great talk. Couple questions, actually. So TMS has been around since the 80s, I think.
Yep.
So I just wanted to ask you a broader question about why it's not more common, in terms of why it's not. Is it just an accessibility issue, or it's been shown to have benefits in a lot of other conditions as well, across a broad range, and so there's a lot of interest for me personally for using this, but what do you think has kind of held TMS back in sort of the broad scale? That's question one, and then I guess I'll start there.
Great, yeah, and thanks for that question. It's a good one. A lot of people have asked that question over time. So one issue is how many of you would feel comfortable telling your boss that you need to take the next 6 weeks off or more, take an hour and a half or 2 hours out of work and drive somewhere and do this and come back, and banker's hours, and so that's the first one, is the timing of it, right? It's that you basically have to, if you're a working person, you basically have to have that conversation, and most people have to have that conversation with their boss, right? And so that's tricky. The second one is the number needed to treat. So with conventional TMS, the number needed to treat to remission is about 6, and so the odds of getting to kind of full resolution of symptoms is not as good as kind of what we're seeing with these more matured technologies that we've been working on. And then it's really it's kind of a conceptualization of mental illness problem, right? I think this year and the last year, there's been a shift away from this kind of idea of chemical imbalance and kind of the frame that had been set for what is the issue to an open question, right? With some of us thinking about this as a circuitry problem, and I think that's all-encompassing, right? I think there's lots of reasons why everybody here can think about it as a circuitry problem, even if your conceptualization is metabolic or diet or whatever. It all ultimately goes into these brain circuits, and I think that as we shift into that new conceptualization, this goes from being kind of weird and off, what is this doing, mixing the chemical imbalance around? I mean, people don't have a way of kind of thinking about it, to, oh, we're engaging a brain circuit that's having an issue, that's having kind of a misfiring or kind of a missignaling problem, right? And if you can shift that thinking, then it aligns more with what the treatment is, and then more people are likely to do it. And so, my suspicion is that by 2030, and the data looks like this, if you look at the trends, by 2030 there'll be a lot more folks using TMS, and it's just a matter of taking the time for all those things to get sorted out, finding a schedule that you can get it done in a week without having to go and tell anybody. You can just take a vacation week and doing it and having greater efficacy and being able to change the frame of way people think about what they think about mental illness. So.
Thank you for that response. I would love to connect with you more also about how to sort of implement that as a primary care physician, and how to kind of refer afterwards. So my second question is sort of about the description of ibogaine, and the effect sounds very similar to MDMA, which I'm more familiar with the literature on that, and I know that there's plans, or it sounds like there's a chance that it'll be legalized in 2024, from what I understand. How would you compare ibogaine to MDMA in terms of side effect profile, or just overall efficacy, things like that?
Yeah, no, that's a great question. With MDMA, it's MDMA-assisted psychotherapy. That's the data, as you know, that's out there. And there's not an obligatory, with ibogaine, there's almost this obligatory slideshow of effects that people end up encountering, right? Where the drug just, for whatever reason, seems to drive people into this phenomenon that's really stereotyped across people. With MDMA, it's more of a psychotherapy, drug psychotherapy kind of synergy effect, and people will re-encounter that trauma, but the drug isn't necessarily driving people into that experience every time, right? And so I think the difference is that with MDMA, it's an empathogen, right? So they're having almost a kind of a positive experience towards this. With Ibogaine, it produces kind of a neutral state where you're able to kind of coldly look at it and be able to experience it and understand it without your own context being brought in. At least that's the way that people have described it, and that's the studies of the phenomenology so far. There's a cardiac risk to both of them. What I didn't get into with what we were doing is we were actually giving people like cardioprotectant dose magnesium right before they got the Ibogaine to kind of take away some of the risk of inducing an arrhythmia. There's a arrhythmia risk with MDMA, although less than Ibogaine for sure. And so, both of those, you're going to have that in the back of your mind. But yeah, I think MDMA as a treatment that's going to likely, as you said, get approved hopefully in 2024, is going to be important because it's going to light the way for a lot of these other meds to come, these psychedelic sort of medications to come out and go through the FDA process. So yeah, thanks.
Incredible. Thank you so much. Appreciate it.